But anyhow, well, I guess it's 8 o'clock, and so we will get started a grand rounds on this beautiful spring day in March in Wisconsin. Delighted to have our own Dr. McBride, and to introduce Dr. McBride, we will have Dr. Andes, our Division Chief of ID. Dave, handing it over.
Thanks, Dr. Schnapp. It's my pleasure to introduce Dr. Joe McBride from the Division of Infectious Disease. Dr. McBride completed his undergrad at McGill before moving to Loyola, where he completed his medical degree as well as residency in both pediatrics and internal medicine. We were fortunate enough to recruit him to our fellowship, where he completed first adult infectious disease training and then pediatric infectious disease training. We recruited him to faculty in 2018, and he is a superstar clinician educator, wears many hats, including directing our clinical services, stewardship, and infection control at Meritor and Select. And I really look forward to his talk today on stewardship. Dr. McBride.
Good morning, everybody, and thanks for attending. Today, we're going to be having what we call an interactive antimicrobial stewardship State of the Union. And so there's going to be some audience participation, and hopefully all of the software gods are in our favor and that it works well. You never quite can tell. But the idea behind this is to get a little bit of a sense from us in antimicrobial stewardship what a lot of our clinicians, providers, and people associated with our department know about the current state of our antimicrobials and the current state of the germs that we see. Where is resistance? Where is there not resistance? So any kind of audience participation that you guys do today would be really appreciated. I recognize that some of you are probably shoveling snow or dropping kids off at school, but those who do have access to their cell phone, please help vote, and we'll show you a little bit how to do that as we go. All right, I have no disclosures to talk about. And this is how you do it through a software called Poll Everywhere. So you would just want to send a text message to number 37607, and then you text WISC ID. Capitalization is not important. And then when the questions come up, you can just answer them. And hopefully in real time, we can see what people are thinking. In addition, there will be a QR code in the top corner that you can always use too, if you prefer that more modern technology. All right, so let's get started. So, antimicrobial stewards. I love the name steward for what we do. And I really do like it because we're not the police. You'll hear a lot of people say the antibiotic police. We're not antibiotic overlords. And when many people think of stewards, movie history is the most challenging tomato eater of all time, Denethor II, son of Ecthelion II, the 26 ruling steward of Gondor, is something else that really pops up in people's minds. But steward, I think, despite what people think, is a great word to describe what we do. And again, for two reasons. One is the definition of what a steward is. And it's a person who controls the domestic affairs of a household, supervising services, directing domestics, regulating household expenditures, and regarded as a servant of both the master and of the people. And I think this is really great when we think about the parallels of this with antibiotics. When we make antibiotic decisions, we have to make the decisions for the patient that's right in front of us, the master, right? This is the person that deserves our most attention. And yet all of our actions and all of our choices have downstream impacts on the rest of the people and society too. And so this word of steward, of managing these resources, is, I think, a great word for that reason. In addition, and this is probably my real favorite reason I like the word steward, is when you look at the breakdown of where it came from. So it's from Old English, steward or stigward. And if you break it down even further, stig means house, and ward means ward or keeper. But stig actually comes from stigu, which is sty. And here it is. I would argue that steward actually means the caretaker of a pigsty. And I think this is a wonderful allegory for what we do with our microbial world here. We are filled with germs. Everywhere we look, it is going to be messy and muddy. And what it is our job in antimicrobial stewardship is try to manage these germs the best we can for the individual pig, for the individual patient, and for the whole sty and hospital and society in general. We know pigs are going to be messy and muddy, but with our help, maybe we can turn them into a pig that looks like this. So what are we going to talk about today? We're going to outline UW's antibiogram and some antibiotic resistant trends. We're going to describe the impact of our antimicrobial prescribing on resistant rates and hospital-acquired infections. And we're going to improve prescribing habits based on a greater understanding of our local environment. All right, so this is what we're going to start off with. This is kind of our warm-up question. So I'd like people to use the poll everywhere software, and sometimes it cuts off a little bit of the question. So the question really is, in 2023 at UW Health, what total number was greater? Was it A, the number of group A streptococcal bacteremias, or is it B, the number of inpatient formulary antibiotics with group A streptococcal coverage? So let's see if this works. We should be able to see if I see some votes. Good, excellent. We'll wait for a little bit more. So think about it. We're a big place. We see a lot of patients, children, adults. Group A strep is a really common infection. At the same time, we've got a lot of different antibiotics on formulary. What do we think is a higher number? Pretty good. So we've got some people voting. Excellent. Wow, great. I really love this answer. So people have, their hunch was correct. We have more number of inpatient formulary antibiotics with group A streptococcal coverage than we had bacteremias of group A strep in 2023. In fact, it really wasn't even that close. 30 bacteremias, less than one a week of group A strep. And yet at any given time, there were 53 antibiotics we could choose from. And I really think that this is an excellent slide to explore just the wide spectrum of what we in stewardship do. There are 53 options on how to treat an infection like this. And learning how to manage this is so important day in, day out. So our UW Health Antimicrobial Stewardship Program is a program that's designed to provide a collaborative, interdisciplinary system for the optimization of antimicrobial use within UW Health to improve drug selection and utilization, improve patient outcomes, and slow the emergence of resistance and reduce antimicrobial expenditures. And I think we're really proud at how good of a job we do at this. There's always room for improvement, but we were awarded a Center of Excellence for this back in 2018, and we're really quite proud of that. So antibiotics are hard. We just want to say off the bat, that's why there are infectious disease specialists and fellowships to learn about all the nuances of antibiotics. And if you're not thinking about antibiotics on a daily basis, there are so many factors into choosing a particular one. There might be the particular clinical diagnosis you're looking at, the possible pathogens that might be associated with it, maybe the local epidemiology of the pathogens that are associated with the pneumonia, having an understanding of where the site of infection is. Am I trying to get antibiotics into the bloodstream, into the lungs, into the bone, the prostate, the brain? Do I know exactly what germ I'm going after, or am I taking my best guess with empiric therapy? There are different pathogen susceptibilities, comorbidities, host factors, the efficacy of a particular agent, the own provider's comfort and familiarity, and then, of course, toxicities, allergies, cost, collateral damage of antibiotics, and then downstream sequelae for the patient population. So there are many decisions about or factors that go into somebody prescribing antibiotics. And we certainly understand that in stewardship. So what do we do and how can we help? Well, every single patient in the hospital who goes under antibiotic therapy, and that is a substantial number, undergoes prospective audit and feedback of all antimicrobial prescribing. So this is a giant undertaking, and the pharmacists who work under antimicrobial stewardship do excellent work every day in really making sure that our patients in our inpatient system are adequately covered and on appropriate therapy. In the event that there could be ways to optimize antibiotics, again, this prospective feedback is helpful in real time in order to talk to the clinicians and optimize our prescribing. We also are actively monitoring our antimicrobial use and trends. I'm probably getting a page about something like that right now. What we do is we will try to find areas in which there might be heightened prescribing in a particular area that we might want to optimize. We review all new antimicrobials for formulary. So anything that's new comes to market, we have to make the decision if we support being added to our formulary here. We create and monitor our antibiograms that we publish online. We create and monitor our UW clinical guidelines and delegation protocols. We serve as advisors to services and units regarding antimicrobial use. We have a research quality improvement group called WinSpire that is publishing information about how best we can optimize our antibiotics. And we man a physician and pharmacist pager to work on the approvals and restriction of restricted antimicrobials. And oftentimes when we get one of these calls, the call might be for meropenem, but really turns into a mini consult at times for individuals. So we certainly do a lot more on a day-to-day basis other than just approve or deny requests for restricted antibiotics. All right, so this is kind of a housekeeping question for me too that I'm kind of curious. Do you know where to find the UW antibiograms? If you were tasked with finding them, where would you go? See, we're getting close to 20. Great. All right, good. 63% of people know where to go, and I'm glad to hear that. For the 37% that don't, we'll make sure we outline exactly where people can find that. All right, how often do you consult the UW antibiogram? Is it a daily visit? Is it a weekly visit, monthly, yearly, or is it a never? Or what's an antibiogram? Monthly, yearly. Yeah, okay, I think that's pretty good. I'm really, oh, it's changing a bit. Yeah, monthly seems like a good idea. We'll go over where the antibiograms can be helpful and where they can't. So I like to get the sense that some people have a good understanding or a reasonable understanding of our local resistance rates. Great. All right, so let's move into a case. We have a patient who presents to the emergency department with 48 hours of progressive purulent lower leg cellulitis and fever. She has got a past medical history of diabetes and tobacco use, and she was hospitalized 6 months ago for a motor vehicle accident. She lives with her son and his partner in Madison. She's a dog owner. She has no recent travel or any kind of fresh or saltwater exposure. She is not currently employed. She mentions that her son and his partner have skin boils over the last couple of months. In the emergency department, she's febrile to 38.4. She's tachycardic to 108. She's a little bit hypertensive, 134/80. Her respiratory rate and O2 sats are stable. Her exam, she's uncomfortable, but she's non-toxic. On her leg in particular, you notice that there's a localized purulent calf ankle induration that extends with erythema from the ankle to the knee. She's got a modest leukocytosis and elevated inflammatory markers. Someone is able to take a swab of the purulence, and of course, not surprisingly, we see gram-positive cocci in clusters. So the assessment of the clinician is that this is a purulent skin soft tissue infection, it's probably Staph aureus. And, you know, with the tachycardia, with the kind of her clinical picture of being a little uncomfortable appearing, there's the possibility that she's bacteremic as well, too. So there's a plan for admission. Blood cultures are obtained. MRSA swabs are obtained. They're going to, you know, look into maybe is there a role for debridement of that and antibiotics. And of course, the question of what antibiotics should be used for a purulent skin soft tissue infection are asked. And really, I think in order to make a good decision about this, you really have to know, well, what are your local MRSA rates, your methicillin-resistant Staph aureus rates? So in 2023 at UW Health, what percentage of Staph aureus were susceptible to methicillin? So 18% methicillin susceptible, 34% methicillin susceptible, 59% methicillin susceptible, 71 or 83. Just this last year, think of all the patients that you saw or all the cultures that you've read. Are you seeing more MRSA? Are you seeing more MSSA? All right. So the majority of people thought somewhere between that 59 and 71%, and a couple outliers from 34 and 83. Okay, let's explore this a little bit. First off, that question, where to find the antibiograms? For the third of individuals who said they were uncertain, well, it's one of those things where you might not know exactly where it is on UConnect, but if you use the nice search function, you should be able to find it by typing in antibiogram. But it's under our clinical hub. And you can note that there are different antibiograms that exist out there, one particularly for inpatients, another for outpatients, and then one for emergency departments. In our inpatient antibiograms, we've been able to break them up into different areas. So our colleagues at the American Family Children's Hospital will have one that really is for the pediatric patients. Burn is certainly a big one, an important one to have a good understanding of their own patient population resistance patterns. TLC, of course, another really important place. And then we divide it up between urine gram negatives and non-urine gram negatives as well, too. Outpatients urology is a really, of course, a big one that they have their own dedicated antibiogram for. So in our patient, we have an ED patient that's coming. So if we were to look at our kind of best targeted information, well, we'd want to look at the emergency department antibiogram. And if you look for our last ED antibiogram that was published, a couple years old, shows that our oxacillin or methicillin susceptible rate for our Staph aureus was around 69%, and that's pretty good compared to other parts of the country. But that was not one of the options that, of course, we had on the question list. Antibiograms traditionally would be information that we'd have to, of course, take over months and years and gather all the data and then publish it at one point. But now with the electronic medical record, we're able to get a lot more real-time granular level data. So we can notice different trends in our resistance patterns much more quickly than we did in the past. So in 2023 at UW Health, the answer is actually 83% of our Staph aureus were susceptible to methicillin, which is a really remarkable number. When we look at different parts of the country, this is a little bit of an outlier. Down in Alabama, where some of the MRSA rates are the highest, about 46% were methicillin susceptible. So the majority of these ones would be MRSA. In a larger urban center and closer to us here in Chicago, a conglomerate of 51 hospitals pool their surveillance data, and they report a 62% methicillin susceptible range. Meritor, our colleagues across town, so very similar patient population, we're seeing 77% MSSA rate. And when we look at our own historical data, this is improving. Back in 2004, our susceptibility rate was 64. In 2011 to 2017, it was 69. And then, of course, in 2023, it's 83% susceptible, which I think is a cause for celebration. However, just how applicable is this 83% to the patient that we are seeing? And this is where it's really helpful to be able to fine tune and really get into some of those granular details with some of our new technology. If we look at our adults in 2023, that MRSA rate drops a little bit to 81%. If we look particularly in adults in the emergency department, that drops to 72%. If we look at adults in the emergency department with bacteremia, remember she came in and was a little bit sick, and it certainly could be someone who's bacteremic. All of a sudden, our methicillin susceptibility rates drop to 53%. And if we look at adults in the ED with bacteremia who were hospitalized within the last year, remember she was hospitalized with that motor vehicle accident 6 months ago, it drops to 33% methicillin susceptible. And so when you consult an antibiogram, that is the environment, right? It doesn't mean the patient that you're actually looking at. And of course, an adult in the ED with bacteremia and a hospitalization and a son with boils, well, who knows what that number is going to be? But there certainly is a trend and a concerning factor that there's a good chance this patient is presenting with MRSA. So when we talk about antibiograms, I think it's really important to understand their help and their weaknesses. So the antibiograms really show susceptibilities of organisms to various antimicrobial agents isolated in a defined area. They may reflect different sites of infection, like urine versus non-urine. And when we look at these, repeat cultures are not counted. So that individual who's hospitalized for 10 straight days of Staph aureus bacteremia, you only take that first one into consideration. So you minimize the skewing. And again, this serves as a general idea, a gestalt or ballpark of the milieu in which prescribing or where our susceptibilities lie. So let's look at our second patient. We have a 61-year-old male presenting to urgent care with a rapid onset lower leg inflammation. There have been 3 episodes and 1 hospitalization of this similar thing in the last 5 years. On exam, there's inflammation on the right and venous stasis changes on the left, and there are tinea pedis between the toes. So you diagnose this as a recurrent, non-purulent skin soft tissue infection. And because of the recurrent and non-purulent nature, you say this is probably strep cellulitis. So in 2023 at UW Health, what percentage of group A strep were susceptible to penicillin? Was it 29%? Was it 52%, 68%, 97%, or 100% susceptibility to penicillin? All right. So we've got a little bit of a varied response. Most people think it's very susceptible, close to 100%. Well, of course, the answer is 100%. Group A strep is universally susceptible to beta-lactams and penicillins. In fact, getting this data is really quite hard for our antibiogram purposes because we don't really even report out the susceptibilities because we have this little isolate that says isolate is predictably susceptible to penicillin, amoxicillin, and cefazolin. And so remember for your group A streps, this is going to be 100% susceptible to penicillin. It's a wonderful marvel about the continued susceptibility to penicillins in these organisms. And for this particular patient who's now had 3 of these episodes, sometimes penicillin suppression could be quite helpful. And usually when we think about antimicrobial stewardship, we think of minimizing antibiotic impact. But in a situation like this, one might argue that by keeping them on penicillin suppression, you might be lowering the risk of different types of antibiotics and hospitalizations and more broad antibiotics in the future. And then as a quick aside, I just want to point out, in individuals with skin soft tissue infections, make sure you're checking between the toes because you will see evidence of tinea pedis, and that's a great conduit to get a lot of streptococcal germs up in the skin and soft tissue. So treating athlete's foot is a big help for your patients. And this is a little bit what I was mentioning about how long-term streptococcal suppression can lower the risk of recurrence of cellulitis in your patients. And so we'll see a lot of these e-consults, questions on stewardship, or even formal ID consults about recurrent cellulitis. And this is something that providers can feel comfortable doing. Oftentimes, we'll use 500 milligrams of penicillin twice a day in hopes of lowering the risk of recurrent streptococcal disease. And you can see that it works quite well. Penicillin also is a quite narrow spectrum antibiotic, so you're really minimizing those other collateral damage that people would be exposed to other agents. So consider this in a patient, especially if they've got recurrent disease. Okay, so here's the next question. What treatment recommended for UW Health's most reported communicable disease in 2023? So this is one of those dreaded two-part questions. First, you have to know what the most communicable disease that we reported in 2023 was, and then you have to know what the treatment was. So in 2023, was the treatment benzathine penicillin G 2.4 million units times 1? Was it doxycycline 100 milligrams PO for 7 days? Was it rifampin INH, pyrazinamide, and ethambutol for 6 months? Was it itraconazole for 6 months? Or azithromycin 1 gram times 1? So think about all these reportable illnesses that we might see from UW Health and think, what would be the appropriate antibiotic for them? Again, the dreaded two-part question. All right, well, great work, guys. So this answer is B, doxycycline. So let's look into that a little bit. Here is a list of all of the reportable communicable diseases that we've seen at UW in 2023. And it runs the entire spectrum of the different infectious diseases and some non-infectious diseases on here as well, too. Far and away, the most reportable infection that we see are sexually transmitted infections, with chlamydia leading the pack at 920. And so you think about your colleagues and think about the patients that we see, know that this is certainly out there, and please evaluate your patients for it, especially if they're having signs or symptoms. The particular one that I brought up this is because the guidelines on how we treat chlamydia infection have changed recently. And previously we would use azithromycin, but due to growing resistance of azithromycin against chlamydia, doxycycline is now the recommendation. So 100 milligrams twice daily for 7 days for chlamydial infections. Great. All right, so let's go to case 4. We have a 33-year-old female who presents to her primary care clinic with dysuria for 2 days. In 2023 at UW Health, what oral antibiotic has the highest rate of coverage for E. coli? Was it nitrofurantoin? Was it cefuroxime acetyl? Was it trimethoprim sulfamethoxazole? Was it ciprofloxacin? Or was it amoxicillin? Oral antibiotic, really common problem, most common pathogen with urinary tract infections. What do we think? Great. Yeah, the majority of individuals got this question correct. So nitrofurantoin is the oral antibiotic with the highest rate of coverage for E. coli. So let's look into that. 98% of all of our urinary E. colis are susceptible to nitrofurantoin. That is an incredibly high number. When we look at oral cephalosporins, this drops to around 90%. When we think of other common prescribed antibiotics that are used for lower urinary tract infections like Bactrim and ciprofloxacin, this drops even more. So really, when you have an uncomplicated urinary tract infection, please reach to nitrofurantoin. And some important things to note about it is that it's concentrated in the bladder itself. And so anything that you're worried about, upper tract disease, that febrile individual, the individual with flank pain, really would want to use a different agent outside nitrofurantoin because it's just really not going to get enough drug to that area itself. Again, remember, lower urinary tract, bladder and down. And then if you read the package insert, it says it shouldn't be used in individuals with a creatinine clearance of less than 50. And this is, again, if they're due to the nature of it needing to be concentrated within the bladder itself. But there is good data to show that it can be used in individuals whose creatinine clearance is really above 30. So for your kind of run-of-the-mill outpatient lower urinary tract infections, nitrofurantoin is really the agent to go to. We actually have guidelines about this here at our institution too, and I think that they're underutilized, and I'm not quite sure if people always know that they're there. And we certainly have a lot that are outside of infectious disease as well too. Just like a lot of the stewardship information, these guidelines can be found on the clinical hub of UConnect. And we have a vast range of different guidelines from COVID use, C. diff, antifungals, CAP, and urinary tract infections is one of them. And you can find that our guidelines say that nitrofurantoin of 100 milligrams PO BID for 5 days is recommended as first-line therapy of uncomplicated cystitis. And I think another great reason to check out these guidelines, and especially for our trainees, is that there's some really good references that are always put there in case you yourself are doing a presentation or you want to consult the primary literature as to how we have made these recommendations. Another thing that we have good guidance on under the guidelines section is beta-lactam allergies. This is a really common question that we are faced with in stewardship and that clinicians see on a regular basis. And something I want to turn your attention to is the chart that we have in there. And so what this chart is breaking down these side chains of cephalosporins and certain penicillins with the idea of, are there certain cephalosporins where I might feel more comfortable using than others based on prior reactions? And so this is a great reference to look at for an individual. They were on ceftriaxone and they had a rash. Am I okay to use, cefuroxime? You might look at this and say, okay, there's a different side chain. Maybe I feel comfortable using it. In addition, something that you'll note that is not on this chart is cefazolin. And that's because cefazolin does not share a common side chain with any other beta-lactam. So that is really helpful to know for things like surgical prophylaxis, which is such a commonly used antibiotic, that it really is quite distinct from other beta-lactams itself. So if you have an allergy question, please pull up our beta-lactam allergy guidelines that can be found on UConnect and consult our recommendations, and this chart could be quite helpful. All right, so it's easy enough to talk about a drug-susceptible urinary tract infection. I think we kind of know what to do. But what if you get one like this? We've come across this issue somewhat frequently in infectious disease where you have a provider who says, I have an outpatient who's okay, who's feeling all right, but has symptoms of a lower urinary tract infection. And then I get the susceptibilities, and this is what it is. So you can see that this is a Klebsiella that's got carbapenem resistance. It's got resistance to oral medications like Bactrim, like fluoroquinolones. What do you possibly do for an outpatient in this situation? All right, so if you are the outpatient physician, how would you treat this resistant urinary tract infection? Would you give high-dose ciprofloxacin, trying to overcome some sort of resistance? Would you give outpatient tobramycin that might be with intramuscular injection or maybe even IV, especially knowing that aminoglycosides have nephrotoxicities and vestibular toxicities that's tough for many people to think about to do? Would you try oral fosfomycin? Would you say, hey, even though you're feeling okay, we should hospitalize you and give you one of those newer cephalosporin beta-lactamase inhibitor combinations like ceftazidime avibactam? Or There's tigecycline susceptibility. Maybe we'll try oral doxycycline in hopes that it works. So where would you fall, and how would you treat this resistant outpatient urinary tract infection? Oh, someone took their vote away. There we go. All right, well, let's see. Oh, great. So most people here said that they would use oral fosfomycin. And I think that's a good job. I think there's a couple different options on here that you can really choose. First off, high-dose Cipro, that's not going to trying to overcome some sort of resistance with more drug generally is not a great approach. Outpatient tobramycin could be an option. A little bit hard to coordinate, but we can talk a little bit about that. Certainly hospitalization for drug-resistant pathogens does occur, but I agree, this is someone who's well. It'd be really wonderful to find an option that didn't involve a hospitalization to treat a simple lower urinary tract infection. So let's talk a little bit about fosfomycin. Fosfomycin is an underutilized antibiotic. It's first approved for UTIs in the 90s, and really just for E. coli and Enterococcus faecalis. It's available as a packet, so it's a unique formulation. Individuals get a packet and then they dissolve it into a cup and then they drink the packet. So it's not pills, not a solution. It's generally well tolerated and there's some mild GI distress. It's unlikely to trigger C. diff compared to other antimicrobials that treat drug-resistant pathogens. There's not a significant amount of drug-drug interactions, and it's approved for uncomplicated UTIs, and generally 3 grams or 1 packet times 1 should be sufficient for a lower urinary tract infection. UW, there's around 96% E. coli susceptibility for fosfomycin, which is really great. However, if you might remember, this was a Klebsiella that was resistant, and let's talk a little bit about the downsides of fosfomycin. It's quite expensive. Many insurances don't like it, and it's oftentimes unnecessarily broad. So for a simple E. coli infection, this is not something I would want to do. Resistance can develop with repeat exposure. And when it starts to use for more complicated infections like prostatitis or pyelonephritis, it's a little bit uncertain how best to dose it. In fact, it's more of an off-label use in those situations. This is a really big one, the poor availability of AST testing, lack of clear breakpoints. So there's good understanding of the breakpoints to give susceptibilities for E. coli and Enterococcus, but other organisms like Klebsiella, it's uncertain what the target really is. And so when we use it for situations like this, we don't have good susceptibility data to really know how often do we see Klebsiella-resistant fosfomycins or not. We don't really have a target. So I think in many times we try this agent for some of those drug-resistant pathogens as an outpatient. You have to call up the microlab and ask them if they'll work it up. And many times you'll have to speak with the pathology resident on call who says, oh, we don't have breakpoints for it. And you say, well, I'd like to at least get a zone of inhibition to learn how much of the growth of it was inhibited by fosfomycin. And that can give you a little bit of a sense of just how efficacious it might be. But really an uncertain about how much susceptible organism is out there. I also want to make a quick pitch for one-time aminoglycoside dosing. This can be given via intramuscular or intravenous dosing. Certainly our urology colleagues have a lot of experience with using IM aminoglycosides for treatment of their resistant urinary tract infections. And it really is helpful and well tolerated, especially if you're using it just as a one-time dose. It can be organized at our infusion centers. Certainly, if you're not something you're really confident or comfortable about, you can reach out to us and we can help coordinate those things. But this could be an option in order to help prevent a hospitalization. And thankfully, when we're giving it for short courses over a couple of days, we're not really seeing the kidney and vestibular toxicities that we associate aminoglycoside use with longer durations. All right, let's go back to the inpatient world and talk about a pneumonia in a hospitalized patient. So we have a 71-year-old female hospitalized with chronic respiratory failure for COVID for the last 3 months, with multiple trips back and forth to the TLC. She has a tracheostomy. The ICU team is concerned about a new pneumonia. Sputum shows Pseudomonas aeruginosa. In 2023 at UW Health, what antibiotic has the highest rate of susceptibility for Pseudomonas? Is it cefepime? Is it ciprofloxacin? Is it meropenem? Is it piptazo? Or is it tobramycin? For our pseudos here, you had to choose one agent that would cover the most. What would that be? Okay, so cefepime at 33% is the first choice. Cipro and meropenem less, piptazo and tobramycin 22. Okay, good. Let's talk about this. The answer is tobramycin. So when we look at all of our samples of Pseudomonas, tobramycin had the highest rate of susceptibility at 95%. Cefepime, which is often our go-to gram-negative rod antibiotic of choice, was 93%. Piptazo, 88%. Meropenem, actually 88%. And Cipro, the last, at 81%. So looking at all samples, if you were just to guess, say, let's put this individual on tobramycin. And these numbers actually get a little bit more extreme when we look at some more of the granular data. So if we look at just sputums themselves, the rate of susceptibility drops for everything, but especially to meropenem. Now it's at 79%. And when we look at TLC sputums in general, our meropenem rate drops to 55% susceptible for Pseudomonas. So this is a frequent call that we'll get on stewardship, in that I've got a really sick patient. We know that they're Pseudomonas, or we're concerned about Pseudomonas. We want them on meropenem. And I really would advise, if there's a particular concern about Pseudomonas, or you're seeing Pseudomonas and waiting for susceptibilities, meropenem is not your best option here at UW, and to consider tobramycin for a short course while awaiting susceptibilities, or a different agent. This gets a little bit complicated because we know that certain other gram-negative rods, like Enterobacters, really respond well to carbapenems, but our Pseudomonas, it does not. So seeing Pseudomonas, please consider other agents outside of the carbapenems. Let's talk about fluoroquinolones and why we love them and why they're great. They have excellent bioavailability. When we think about oral and parenteral therapy, they're really equivalent, excellent levels. They're broad spectrum. Of course, they're our only oral anti-pseudomonal. They have a high volume of distribution. They can get into the bone, they can get into the prostate, and they're relatively inexpensive compared to a lot of our other antibiotics. Many good qualities of fluoroquinolones exist. But what are some of the downsides? Here are a list of black box warnings that the FDA has put out against fluoroquinolones. And started in 2008, describing tendinopathies. And then in 2013, the second black box warning occurred, describing of a lot of neurologic toxicities, like exacerbating myasthenia gravis crises, peripheral neuropathy, and CNS toxicity, especially in the elderly. In 2016, they made a big statement that said fluoroquinolones should be avoided in uncomplicated infections. So all those standard community-acquired pneumonias with moxifloxacin, all those standard lower urinary tract infections, even the high lows that are going according to plan, please find a different agent outside of the quinolones. And then in 2018, the most recent black box warning included the risks of hypoglycemia, mental health changes, and something that's really quite devastating, aortic dissections. And so please choose a different antibiotic outside of a quinolone when possible. Other things to consider about quinolone downsides is that there are a number of drug-drug interactions with quinolones, especially ones that have QT prolongation issues. Quinolones in general have a low barrier to resistance. It doesn't really take much more than a mutation or two in order to render the class resistant. And of course, the concerns about C. diff infection. And so, because of a lot of these concerns about fluoroquinolones, a lot of institutions have thought about limiting their role. In about 10 years ago, we had quite a high rate of C. diff in our hospital, and paired with a number of other black box warnings and concerned about fluoroquinolones, we began to limit their use, first in a couple different inpatient units and then hospital-wide. And here you can see our antimicrobial days of therapy per 1,000 patient days for ciprofloxacin. And look how much it's changed over the last 10 years. Now we are getting, or is about 47 days per 1,000 therapy, and now we're about 2 to 3. So we've dropped it greater than a log in our quinolone use over the last 10 years, which is really remarkable. And I like this chart here too. It's a little bit busy at the moment, but even at our colleagues across town at Meriter, we don't have a fluoroquinolone restriction over there. And what's really interesting is if you follow this pink slide here, pink line, even without restricting it at Meriter, look how much the Meriter fluoroquinolone rate has dropped. Just really showing a lot of our shared providers going back and forth to different areas and kind of the culture of quinolone use around the city. So certainly there are downstream impacts of what we do here at UW Health. So what does this mean regarding our coverage? Well, in 2004, we looked at our quinolone coverage. 90% of our E. coli's were covered by it, and 69% of our pseudomonases were covered by it. In 2011 to 2017, this dropped to 74 and 79. And this is really the last good data we have before a lot of our restrictions came out. So how are we here today? Well, to be honest, not much different in the inpatient setting. So our E. coli is around 75% and our Pseudomonas is 78%. So even with all of this work that has gone on to limiting the quinolones here in-house and all the benefits that we get about not having drug resistance, managing, lowering our C. diff risks, we're still not seeing a big change in our susceptibility profile. And likely this is because quinolones have a large burden in the outpatient world. And this really highlights kind of the next frontier for UW Health stewardship. I think we're really active in the inpatient setting, our prospective audit and feedback. We're reviewing all these antibiotic choices. But boy, that is so incredibly hard for providers and stewards to do in the outpatient world. If you're seeing a patient in clinic, you don't have that luxury of having hours to go and to talk to pharmacists to make a change later in the day. You have to make that decision right then and there. And finding good resources quickly is going to be really an important part of how we can reach our outpatient stewards or outpatient providers moving forward. All right, so in general, the stewardship, we're not police, we're not overlords, we're not some sort of a despot. We really want to be caretakers of our communal pigsty, and we are available for questions, for concerns, and really we know that we're never going to make our pigsty clean, but we can make it cleaner. And I just want to give a quick shout out to my family and how stewardship plays a part in my life and infectious disease in general. You can see this is a picture of our canoe, our family canoe, the Antimicrobial Stewardship. This is our family's hockey team, Doxy Ison, and then our family dog, Rubella. All right, well, thanks for your time, and I'll take some questions.
Hey, I do really like the family dog. Have you had other pets? Are you going through all of the infectious?
Yeah, right. We don't have any others yet, but our next one is going to be Roseola. That's the next plan. We'll call her Rosie, and then maybe Ike and Sammy, and go from there.
Great. Well, I have a couple of questions actually. So one is more of a pragmatic question. In terms of the antibiotic RAMs that you showed and the specificity of inpatient, outpatient, et cetera. So are they location specific or patient type specific? So I'm the MICU attending. I have a MICU patient who happens to be located in the burn ICU. Which antibiotic gram do I look at?
Yeah, so they are going to be unit specific. And this is something that we have better data now with how our electronic medical record works, is that we can really track where the order was placed. Of course, just like you mentioned, our patients move all over the hospital and there's always changes. So it's going to be imperfect, but we will be able to look at where the order was placed of the individual. And then there's another way to look at as to the primary service as well, too, who's caring for them. So that's where you might get a situation where you look at, burn service, if they're seeing someone elsewhere, but they're still the primary, maybe that will reflect differently. But we can really look at both, but I would urge looking at the unit area of that particular patient.
Great. And then my second question, which you didn't quite address, but touched upon. So the patient you presented multiple in the ICU, I hate the TLC name, I'm just saying, who is in the medical ICU, recurrent infections, tracheotomy, etc., who has Pseudomonas in the sputum. How can you help differentiate colonization versus a pathogenic organism? That's one of the struggles we have all the time.
Boy, this is it's a big struggle for us too. And what I will say is that on a micro report itself, you cannot tell if somebody is colonized or infected. So there's nothing on that culture that's going to tell you that. How you learn about that or how you think about that has to be a clinical decision based on all of the patient factors. So when I'm looking at a culture report, that's in isolation. And then looking at the patient in general. So are there new fevers? Are there new infiltrates? What are the white count doing? What are the O2 sats? Asking the nurse, are you suctioning more? Looking at the patient, how do you feel? All of those factors go into making that determination of, is this a colonization or is this an infection? So yeah, same thing with asymptomatic bacteriuria and our urinary tract issues. This is always a big one. So really take that pause when you're looking at a culture result and say, am I treating the patient or am I treating a culture result? It's really hard to do sometimes.
Great. Cool question from Steve Marshall. Where do you see the role of AI in antimicrobial stewardship?
Oh boy. Well, as the person who really struggled just getting the Poll Everywhere software working this morning, I'm probably not the best person to ask about up-to-date technology. But I think AI is really interesting in thinking about different risk factors. They can probably, in a computer-based system, could probably pull out risk factors more quickly than we can. So, that question of a person who has exposure to boils, or maybe exposure to water, or living in a different zip code, all of that data might be more easily and readily available in the future, and really getting that granularity to help predict. But it's an excellent question and one that I hope somebody else might answer.
Right. And then what's the impact of prior antibiotic use on culture results? This comes up all the time. Patient got 1 dose of vancomycin, then the blood cultures were drawn. How does that influence your choice of antibiotics based on the culture results?
Yeah, I think this is another great question with understanding the situation in which your culture was obtained. So similar to that colonization question, knowing in what pressure this culture was obtained in is really important. So a great example might be endocarditis. Some of these endocarditis are caused by strep organisms, which are so susceptible to antibiotics. And they could be ravaging and damaging a valve and creating brain abscesses and all these problems. And yet you give a whiff of ceftriaxone and it'll spoil your cultures. So what I do is that, at least in the inpatient setting, it's quite easy to tell what the time of a culture was obtained and what antibiotics an individual was exposed to prior. And you have to bear that in mind. So if someone received vancomycin before that blood culture, you're absolutely right. You might be missing a positive bacteremia. Sometimes things can break through, especially if the burden of infection is quite high. But you have to understand that your cultures are just like anything else and not 100% objective.
And then I'm going to rephrase a question a little bit. What do you find the most common causes for providers who perhaps go against what the susceptibility panel is provided and request a different antibiotic? Are there common rationales for that?
Well, I think, some of the more common concerns that patients have or that providers have are really regarding allergies. I think clicking over on an allergy tab and seeing what a lot of our patients have listed as allergies is daunting at times. And certain patients really have quite a long allergy list. And so, you look and it says, trimethoprim sulfa is highlighted yellow, and beta lactams, there was a rash, and next thing you know, you really want it, asking for a quinolone or something like that. And really at that stage, I would then go back to the patient and explore, well, really, what were these allergies? How much do we believe them? Consult our beta lactam allergy guidelines, find out if these are true contraindications or not, and maybe retrial some of these. All of this is so much easier to do in an inpatient setting than an outpatient setting, of course. But that's a really common issue, is the concern of allergies and what's true and what's not, and how to make a good prescribed decision.
Do you see that as a potential use for AI, integrating the allergy tab with like the antibiotic susceptibility panel, so you don't have to do that matching up?
That sounds like a great idea.
Great. How do you advise patients who are reluctant to take antibiotics because they don't like taking medications, et cetera, who need treatment? Do you have an approach for that?
That's a good question. I think the majority of patients, I might have a little bit of a selection bias, and if they're coming to see us an infectious disease, that they oftentimes have an infection that warrants treatment, or maybe they've been dealing with for a period of time. So generally, I'm not faced with too many patients unwilling to take antibiotics. I think how I would approach this is really describing the natural history of a particular infection and the risks of an untreated infection and the risks of a particular medicine, and being upfront as to how our antibiotics have limits and side effects and toxicities, but so does an untreated infection, and trying to balance that to the patient.
And then getting back to the question about prior antibiotic use. So for a patient with suspected endocarditis who did receive antibiotics, their cultures are negative, continue the current course of antibiotics, how do you manage that one?
Yeah, and if somebody has confirmed or at least concern for endocarditis, like they maybe on an exam have a new murmur, maybe stigmata, maybe on an echo there's a vegetation that's there. If your cultures can't help, then it would be culture negative endocarditis if they enough to meet criteria, in which case our targeted therapy has to be more broad. If patients have enough clinical signs and symptoms, even with an absence of a positive culture, we would recommend treatment, generally with resistant gram-positive coverage and something like ceftriaxone on top of that. Sometimes, too, there could be atypical organisms, and there's a role for doxycycline for things like Q fever. So this is what our ID colleagues are here for, is to kind of help navigate that in the event it happens.
Yeah. And so you talked about the antimicrobial stewardship turning into kind of a mini consult. What is the breakpoint between a simple, yes, no meropenem versus actually providing a true consult to help guide that complicated patient?
Yeah, this is something we as a group talk about a lot, is that where should our role as stewards on that quick 333 pager end, and where should the consult service take over? I think a lot of people would say, if I can answer a question in one or two quick answers, it's probably okay to just give them information over the phone. But I think this kind of curbside consult question comes up a lot in different specialties, and you worry about some of the nuances of just rattling off information without actually formally seeing the patient. So usually if it's complex, it's not something that there's a quick, easy answer for. We'll urge an inpatient consultation. But lots of times people might say, hey, I'm discharging a patient and I'm thinking about using a quinolone. Is there another option that's out there? And in that patient, the stakes are a lot less. And they have the opportunity to do a little bit more teaching about options, especially moving out of the hospital.
Dave, any other questions from you?
Great
I will say,
job.
yeah, comments from Bob Probelski, the best talk on stewardship ever heard, which I would echo, informative and fun. So thank you so much, Joe. A wonderful overview. And looking forward to meeting rubella, maybe chlamydia in the future.
That's a good one, clammy. Yeah. And thanks for everybody who participated in the voting. That's really helpful to get a sense of where we can improve and what people are thinking in our community. So thanks.